This is Dr. Aburas. In previous presentations, we discussed the pathologic nature of pulp calcification. Today, we're going to focus on the anterior teeth pulp calcifications. I indicated that the problem is pathologic, and that is endodontically speaking, clinically speaking. The problem of pulp stone, pulp chamber opacities, canal calcification of posterior teeth, there are so many. We listed in the Instagram about 13 causes. But when it comes to anterior teeth, the causes are very limited. Actually, two, in majority of the cases that we see clinically. Trauma, specifically luxation injuries, and aggressive orthodontic treatment. In this presentation, we're going to focus on the management, the diagnosis, the treatment, the different approaches of anterior teeth pulpal calcification, specifically the maxillary and the mandibulars, because there are some differences. Let's go to the slides. Performed in France by Dr. Lemay, in which he used electron probe microanalysis of human dental pulps. This is a pulp chamber, this is calcified vessels, and this is a pulp stone right in the middle of a canine canal, separating the pulp into coronal portion, starving, and a radicular portion. What's important about the study is the chemical composition of the pulp stone or the calcification they studied. You see minerals, calcium, 32%, phosphorus, fluorine, sodium, magnesium, potassium, chlorine, manganese, zinc, and iron. All of these turn the pulp chamber, which is a loose connective tissue, into a mineral compound. And you see it perfectly here, how this calcification taking the shape of the pulp chamber right here. This is actually the pulp stone I removed here. And you can see this is similar to that other one, which is blocking the canal. So the loose connective tissue, the rich cells, odontoblasts, undifferentiated stem cells, blood vessels, nerves, all in the pulp chamber. And when the pulp chamber is gone by amputation or by pulpotomy or by calcification, then we have nothing. The canals are just pathways to the pulp itself. So the loose connective tissue has been replaced by mineral components. Trauma is the primary cause of anterior teeth calcification. And the result, the outcome, either pulp necrosis and AP formation or pulp calcification, as we see here. With that, you could get some tooth discoloration. In both of the situations, the luxation injury is the prime cause. And whether it is subluxation, lateral displacement, intrusion, or extrusion, the result is gradual atrophy of the pulp and gradual apposition of calcium and other minerals. A second reason or cause of anterior teeth calcification is aggressive orthodontic treatment. With the pulp necrosis and AP, we perform non-surgical endodontic treatment and surgical endodontic treatment with predictability. 86% for surgical, 92% for non-surgical. And you can see all this pathology is now have been replaced with native bone from the same patient. And you see here, we actually looked for a canal and there was none. We could not get down. And therefore, because it's the expediency of the treatment, it was non-surgical and surgical combined. The problem is not those canals where you have a patent canal. The problem is these. When patients are symptomatic or they have signs of pathology, like you have here, lamina dura involvement, periodontal space, and changes in the periapical bone. When you see all of this, periapical pathology, how you're gonna treat those cases? Pulp calcification impedes standard endodontic treatment. Actually, it makes it impossible. And the solution is to search for the canal and go nowhere. So this is why I'm going to focus on now. I'm going to share some cases and go through the diagnosis and the management the way I see it today. I use the 4R operational diagnosis, and I start with the patient history, the patient pain history or profile. Patients having pain, in this case, this is a virtual patient, either has that's acute abscess, early acute abscess, or early AP. They have pain, they have a history of trauma, they also may have a history of orthodontic treatment. The pain is recent, is constant, and occurs spontaneously. Relieved no medication, and sometimes they tell you, because if they have an abscess, cold drinks or rinses with cold water or ice water helps them. And the tooth may be tender to percussion or touch. Then we go to R2, the radiographic findings. And of course, we introduce the 10 ADI. That is going from the crown down all the way to the apex. And you see now how the crown is basically intact. The pulp chamber is calcified, the canal orifice is calcified, the canal itself is calcified, the apex is calcified. And then we come out and we see the periodontal ligament is gone, the lamina dura is gone, the interproximal bone is gone, and periapical bone is involved. Adjacent teeth, there's a sign of trauma. If the patient is asymptomatic, where you have no periapical pathology or initiation of that, you'll see again the crown is intact, and you could actually follow. You'll see again pulp calcification in the chamber, the canal orifice, the canal itself, the apex, and you go and then you see the lamina dura, in both lamina dura intact all the way up, and the periodontal space is available. The interproximal bone intact, the periapical bone is intact. This is a calcification with absolute different prognosis from the other one, and a different diagnosis and different treatment. So the testing, R3. The only test we perform is the cold test if you have a pulp chamber traces of remaining canal. Sometimes the canal receded to the cervical zone, and you do go down all the way to the cervical zone. But usually it's a very remote, distant feeling, sensation, rather than pain. The only test useful if a patient has symptoms, AA or AP, will be the percussion test and the palpation test. If you have a fistula tract, it should be traced. We perform a complete periodontal assessment, the traditional, the pocket depth, the clinical attachment level, the bleeding test, the Miller mobility test, and then fistula tracking if present. R4, that is the restorative conditions and tooth structure evaluation. If there's no crown fracture, the crown will be intact. You may have some discoloration. You may not have any restoration, but if you do, please look for coronal microleakage. You may have some enamel crazed lines, they stop at the CEJ, or you may have line cracks. And in those cases, you have to rule out tooth cracks. And then you need to look at the tooth wear, which will be essentially the attrition, erosion, and abrasion. As I mentioned, there's about 40% of it will be tooth discoloration. Now we come to the management, the clinical management. We covered the diagnosis. Now we're going to talk about how do you handle. You may not necessarily to treat, you may want to refer the case. But how do you manage these cases? Some cases you just wait and see. Some cases you need to act. Some cases you need to refer. Here's a case in which this patient came symptomatic, and you can see there's a pulp here, pulp everywhere. This canal is calcified. The patient was symptomatic, and you see changes of the bone here. The tooth was discolored. We initiated non-surgical endodontic treatment. We got nowhere, absolutely nowhere. Then, we use a microscope, we use lenses, with the transillumination, all the tricks and the tips and the tools you have, you try. None of them take you to the objective you want, the foramen, the apical 1/3. The only way to get to the apical 1/3 is surgical, endodontic surgery. Most of these trauma cases, most of these calcification cases, they have patent apical third. And we end up doing surgery. We've done the surgery. Here's the window, which we created. And here is the healing. And then, because we already have an access opening, we took advantage of that and we bleached the tooth. Second case, same thing, symptomatic. Lamina dura is gone, periodontal space, and the patient symptomatic. We make access opening, we go nowhere, we end up doing an apical retrofill. Again, observe how large that apical retrofill. There was root resorption right at the end, but the radiograph did not show it. And this is the advantage of apical surgery. You see it really as it is, not in two-dimensional. Another case. We made the opening, we got nowhere. Filled the canal, and then switched to surgical endodontics. Here's the retrofill again. You can see this amount of huge resorption. This is the apical foramen actually with resorption. And we filled it, and here's the healing. Observe the return of the lamina dura over here. Observe it how it's gone over here. This is the sign of the lamina dura, which I always say. The lamina dura is the first to go, the last to come back with healing. So, what's my conclusion? The conclusion that non-surgical endodontic treatment of pulp canal obliteration of single-rooted teeth, specifically, again, I'm repeating, the maxillary 6 anteriors, canine to canine, in the American system will be tooth number 6 to tooth number 11. The treatment, in my opinion, after doing so many cases at USC with my graduate program, we made the conclusion that when the patient is symptomatic and you have to do the root canal, you absolutely go directly to surgical endodontics. Because non-surgical treatment is clinically unpredictable, technique sensitive, time consuming, mishap prone, destructive sometimes, and you could create into your own canals and you create perforations and actually risk the loss of the front tooth. And in our clinical experience, we always ended up with surgery. So this is why we created this rule. So rule number one, if the patient is asymptomatic and you have pulp canal obliteration, no symptoms, again, you take a get head-on x-ray and you could see the lamina dura, perfect. You'd see the space, again, lamina dura, periodontal space, intact bone, intact interproximal bone. Same thing here. In those cases, you follow rule number one, strict annual radiographic clinical exam. Rule two, the patient is symptomatic. Early signs of AA, that's acute abscess, or AP, apical periodontitis, you lose the lamina dura at the apical third. Focus on the apical third. And thickening of the periodontal ligament space and changes in the bone. What situation? In those cases, okay, we basically go directly to apical surgery. And we do basically curettage, examine the area, and many times we are able to access the apical third and fill it, or we do retrofill. Rule number 3. Rule number 3 is specific for mandibular teeth. Symptomatic PCO on mandibular anteriors, okay, is different from the maxillary because those two entities, the AA and AP, we do access and look for a second canal. Usually there's a buccal and lingual. We look for it. And if we don't find it, we proceed to do surgical endodontics. And this is how we obtained this situation. Here's a patient came to us with a fistula. We tracked it. And this is a radiograph, a retrofill which is loose with an apical lesion. And I made the access, looked for a second canal, did not find it, placed composite back, and it's a 5 minutes rule. You use your magnification, microscope or lenses, use transillumination, use methylene blue, use every tip and trick you have. You don't see it, you go to surgery. And you do this ahead of time when you inform the patient that they're gonna need surgical intervention. And then, sure thing, there was a second canal, second orifice. We treated it. You can see here 2 retrofills, and here's the healing. Look at the lamina dura return, and we have healing. Now, why is this rule number 3? It's because of this information. 75% has 1 canal, lower anteriors, but 23% have 2 canals. 2 canals, we call them confluent. They start 2 orifices, end up 1 at the apex. But so if the root canal is no good, the second one will activate and create a problem. And about 3% have actually 2 and 2. That will be like 2 orifices and 2 apical foramens. And look at the canine. The mandibular canine, that's tooth number 22 and 27. And this is why we called it the rule 22 to 27. We always have to look for the canal before we initiate surgical endodontics. And you can see here that tooth 22 and 27, they have 27% 2 canals. And look at my collection of APCs. This is all mandibular canines. Thank you for listening.